On behalf of the American Heart Association and No Diabetes by Heart, I would like to welcome you to today's webinar, Foundations of Brief Behavioral Counseling for Healthcare Providers. My name is Anmol Dalwadi, and I'm the Quality Programs Manager for Quality, Outcomes Research, and Analytics with the American Heart Association. Before we begin, I'd like to quickly review how to use this webinar platform for today's event. If you'd like a copy of today's presentation, you can download a PDF in the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please contact the GoToWebinar customer service team found in your confirmation and reminder email. At the conclusion of today's presentation, you will receive a link to access today's recording as well as an invitation to complete our feedback survey. You will have the opportunity to submit text questions to today's presenter in the questions section. You may send in your questions at any time and we'll review the questions during our Q&A at the end of the presentation. It is my pleasure to now introduce our speaker for today, Dr. Angela Fidler Pfammatter. Dr. Pfammatter is a licensed clinical health psychologist and assistant professor of preventive medicine at Northwestern University Feinberg School of Medicine. She has an extensive background training students, clinicians, and health coaches in best practices for behavior change counseling. Her methodological area of expertise is in using optimization research methodology to develop mobile behavioral health interventions. Her clinical expertise is in behavioral weight loss. Dr. Pfammatter's research program seeks to optimize multiple health behavior change interventions to prevent cardiovascular disease in adults. It is now my pleasure to turn today's presentation over to Dr. Pfammatter.
Thank you so much, Anmol. I'm so pleased to be here speaking to you today about brief behavioral counseling for healthcare providers. I have nothing to disclose, and the slides are not advancing. Just one moment, folks.
There it goes.
There we go. So today our objectives are several. Hopefully by the end of today, you'll be able to describe some advantages for using brief behavioral counseling in any kind of clinical encounter. To summarize some primary foundational aspects of motivational interviewing as an approach to speaking with patients about behaviors. To express or give examples of motivational interviewing based skills, and to demonstrate what we call ORS skills, so that you actually walk away today with something to practice, something to implement right away. But first, we're going to talk a little bit about human behavior in general as it pertains to what we do as clinicians and healthcare providers. Generally, when we look at overall medical recommendations, we see adherence rates around 25%. Not so great. And those lower adherence rates are really connected to things like complex medical regimens that we may be asking our patients to do, or preventive behaviors where individuals don't really see the payoff or the benefit right away. Medication adherence rates are a little bit better, but still pretty abysmal at 50%. And when we look at things like cardiovascular disease, we see that about 90% of premature cardiovascular disease being attributable to modifiable risk factors, and yet only 3% of our US adult population is actually engaging in all of the health behaviors that we would like to see, like non-smoking, having a healthy body mass index, doing enough moderate to vigorous physical activity, and eating 5 fruits and vegetables. So there's a lot of work to be done in terms of promoting health behaviors for the prevention of cardiovascular disease and prevention of diabetes. So what can we do as healthcare providers? Well, there are significant barriers to facilitating health behaviors in our patients. And when we survey, talk to clinicians, review the literature, we really find two main barriers, and that is a lack of time and a lack of training. And we'll speak to those today. This is a little bit of training that you can, walk away from today actually being able to use some of the skills that we'll talk about today. And I'll talk a little bit about how you can actually work these skills into your typical encounters without adding additional things on to your encounter. It's an approach that you can use, that you can integrate into your conversations so that it's not taking additional time. You're just having more effective conversations to facilitate the behavior change that you're asking for. We know that physicians providing behavioral counseling, those rates are really poor in the US. So we're gonna first speak to why people don't follow our advice. Then we'll move into the approaches that we can use, that foundation of motivational interviewing, and then we'll get into those specific skills. We'll start the conversation here with talking about why healthy behaviors are actually abnormal behaviors in our society, why behavior change is so hard, and how we can identify problems within our existing clinical encounters and facilitate a conversation with our patients so that they walk out the door more likely to follow our recommendations. So first, a word about motivational interviewing, because I think a lot of people hear about motivational interviewing and think of it as something that is this really large, complex intervention that they may not be able to implement in their clinical practice. What we know about motivational interviewing and why we use it as an approach is that time and time again, we see that as clinicians begin to fold it into their approach to their clinical encounters, we actually see quite positive outcomes. So motivational interviewing is more of a framework for engaging in more effective conversations with our patients. There are some concrete skills that we'll get to today that you can use, but the general framework is meant to be an approach to a conversation that is really easy to integrate into your current clinical workflow, into your current conversations that you're already having with your patients. Motivational interviewing is not psychotherapy. It's not a standalone intervention. It shouldn't add additional time to your encounters, but it's also not a skill that you can pick up over a weekend. So we'll talk about the framework in general and those foundational principles of motivational interviewing. You can, there's actually a book that is referenced here at the bottom of the slide. And again, you can download these handouts. That is Motivational Interviewing in Healthcare. That is a really great resource if you're interested in diving deeper into motivational interviewing. And there are also like very intensive trainings you could attend as well to be more competent in using motivational interviewing in your practice. But today I'm going to talk about 4 very specific skills that you can walk away and start practicing. But motivational interviewing in general, you could go much deeper if you were really interested in that. Today, we're just going to go over the highlights. I seem to have lost advance. Okay, there we go. I got it. So first, why is it so hard for patients to follow our recommendations? I mentioned before, healthy behavior is abnormal behavior. If you think about the everyday environment in which we exist here in the US in particular, and how we're just bombarded with cues to overconsume, to overeat, to not be physically active, to be sedentary, it is really hard to go against those easier choices. It is easier to choose an unhealthy food than it is to choose a healthy food in many contexts. It is easier to sit down on the couch at the end of a really long day and watch Netflix than it is to push yourself to go do some serious physical activity. And as humans in general, we often have a preference for short-term gain over long-term consequences. But more than that, there's also usually some kind of purpose for the unhealthy behavior that we are engaging in. So when you're asking your patients why they're smoking or why they're not doing enough physical activity or they're being too sedentary, those kinds of examples, you want to start to think about what purpose is this behavior serving this individual? Is it coping with stress? Is it just that it's easier and they don't know other behaviors to do? Do they not have the skill to, say, cook a healthy meal? We want to really think about how that unhealthy behavior actually serves them. And then when we're talking about lifestyle behaviors in general, we're often up against some lifelong habits that we're asking people to change. So if someone in a clinical encounter with you is discussing with you that they need to change their diet, but they've been eating a very particular way, say for 45, 50 years, you have to understand that we're really going against the grain. We're really asking them to change some kind of habit that they've built up over many, many years. So all of these things can kind of work against us when we're asking people to engage in healthy behaviors. When we're having conversations with our patients, one thing I want you to really think through is, what is the actual problem? Many times when we provide recommendations during an encounter and we see the patient again and they're not doing the behavior, whether that's taking medication, following some sort of regimen, going to the physical therapy you recommended, doing more physical activity, whatever the case may be, we often assume that they're just not motivated. But there's actually sort of three categories of problems that we can diagnose in a way as to why that individual is not doing the behavior. And that can be super helpful when we're trying to get down to what needs to happen in order to facilitate that change in behavior or facilitate that individual following through on the recommendations that we've given them. And those three basic problems are motivation, behavior, and emotion. And we'll go through those three. The first is motivation. And again, this is what we often jump to assuming. If someone's not engaged in a behavior we're asking them to do, we assume that they don't have the motivation to do it. That may be the case, but how do we know that for sure? So first, let's just think about motivation in general. What does it really mean when someone doesn't have motivation to do something? And I use this example of the crisper drawer effect. So if you think about your crisper drawer, if you're like most Americans anyway, I want you to think about, how often do you really fill your crisper drawer with, say, fresh fruit and vegetables? How much of that produce by the end of the week or so do you actually end up throwing away? And if you're like most Americans, you have this cycle of going into the grocery store, seeing some fresh fruits and vegetables being really appealing to you. You purchase them, you take them home, you put them in the drawer, and then they kind of sit there and rot. Now, why do we keep doing this over and over and over? The problem may not be in your motivation to buy the fresh fruit and vegetable. We have to think about all of the behaviors that go into eating and consuming fresh fruits and vegetables. There is a motivation for buying that is different than your motivation to prepare those fruits and vegetables, and that is different than your motivation for eating, right? I may have a lot of motivation for buying all of those fresh fruits and vegetables when I'm in the grocery store and they look really appealing. But by the time I get home, maybe I'm too tired to prepare. I have very little motivation. And maybe I don't actually like fruits and vegetables all that much, so my motivation for eating is low. We're asking people to engage in a chain of behaviors to get to this end result, the recommendation that we've made to eat more fruits and vegetables. So the question is, are we really assessing motivation for the right behavior? Are we really asking about all of those smaller behaviors within that larger recommendation that we're asking about or asking them to do? And are we expecting motivation to endure beyond what is reasonable? What do I mean by that? If I know that I've got a patient who is, quite stressed out, maybe works a couple of jobs, maybe is working and going to school, they tell you, I don't really have a lot of time, and yet they continue to go to the grocery store and buy the whole fruits and vegetables that sit in their crisper drawer, well, then you know that you might need to be making recommendations around buying more pre-prepared foods, or at least going into the freezer section to buy chopped fruits and vegetables that they can work with very easily, very quickly. We often expect our patients to do things or to have motivation for behaviors that are a little bit too high of a bar, at least at first. So we want to be asking these questions about these smaller chunks of behaviors to get to that larger recommendation, and to do it in a way that the patient feels like they can actually do it, that they have the confidence and the ability to do what you're asking them to do. One way we can assess motivation comes from a brief behavior change counseling technique. When we ask about motivation, we often ask about things that are too global or too robust, not specific enough. If you think about just asking a patient, do you want to be healthy? Most of your patients would probably say yes. It's not specific enough. It doesn't give us enough information to know where the problems actually lie. We can actually assess motivation via a very quick 4-question assessment that gives us a lot of information about where we can start and where we can meet the patient so that they actually leave your office or leave the encounter more likely to engage in some form of the behavior that you're wanting to see. If you're interested in more information about this or want to watch videos of people role playing this, there's a reference here on the slide that'll get you to the article where this is published. But Michael Vallis also has a Behavior Change Institute website that you can go to that does a really nice job of getting into the weeds of using these techniques. So if you're interested, you can go there. But the way we can assess motivation for any kind of behavior, remember, we need to be specific. We can ask them if they think the behavior is a problem. Now, if I'm asking my patient, do you think smoking is a problem? And they say no, you know right away that there's very little you can do in a very brief encounter to move the needle on getting them to stop smoking. It gives you a lot of information right away. If they've got high blood pressure and you're trying to prescribe some sort of medication, do you think your high blood pressure is a problem? If they're answering no, you've got to go in a completely different direction than just writing them a script and saying goodbye, right? We can also ask, are you bothered by this particular behavior? Are you bothered by your symptoms? Are you bothered by the behavior you're doing? This can give us some sort of idea about how distressed they are. And that's important because if an individual is not distressed with the status quo, they're unlikely to change. Then we're asking, do you want to change this behavior? Do you want to change your healthy eating? Do you want to change your physical activity? Do you want to change how you're getting winded going up and down stairs, your fitness level, that sort of thing? You're getting an idea about how willing they are to make a change. And then lastly, are you interested in changing now? This is an important one because sometimes we'll ask people if they want to change and they say yes, but when you start to get into the specifics of it, you find out that they're not actually ready to do anything about it right now. And that can be for all kinds of reasons. I've got a couple of really stressful weeks coming up in work. I don't know if I can quit smoking right now. Or, I'm about to go on that all-inclusive cruise. I don't know if I can start eating more fruits and vegetables right now. It gives you that little bit of information to know which direction you can take in planning out or collaboratively working with your patient to arrive at a reasonable recommendation for the behaviors that you're going to be recommending as they're walking out the door. 4 quick questions. They're basically answering yes or no. One thing to look out for is people saying no in different ways. You'll hear people hedging a little bit, right? They'll say things like, well, if only I had more money to buy fruits and vegetables, I would do it, right? That's a little bit of a different problem you've got to tackle there than just motivation to purchase. They might say, yes, but that's really a no. It means that some other barrier is in the way that they see that is not able to be overcome in order to do that behavior. So we need to be listening out for those I guess, hidden answers to some of these questions to really get down to how the patient is thinking about their health behaviors that you're asking them to do. We can also dig around a little bit in finding the reason why an individual wants to do something and how much effort they're willing to put forth. if we're asking people, why do you want to be healthier, you're going to get various answers. That may not be at all related to how confident they are or how much effort they're willing to put forth to do those behaviors to be healthier. But if we ask a slightly different question to say, about how much effort are you willing to put forth to get healthier, then you're getting a little bit more information about what they're willing to try and how much they're willing to push in order to accomplish said behavior. And if you get even more specific, such as why do you want to be able to climb more stairs, or get on the ground and play with your grandkids, what amount of effort are you willing to put forth to get off of this blood pressure medication, then you have an idea about what kinds of suggestions you can make that might be reasonable for that individual to try. It's also important to realize that there is a difference between short-term motivation and long-term motivation. Short-term motivation can often come right as a crisis happens. So if you're seeing someone inpatient and they've just had some sort of medical crisis, it is a great opportunity to get in there and talk about some lifestyle behaviors or some medication adherence issues or other types of recommendations. They're likely to leave and do that behavior right away because they're going to be really distressed and they want to do things to get rid of that distress. But what happens a couple weeks from now, a month from now, 2 months from now, when the distress of the crisis is gone and that experience is further in the background? If we don't have some sort of long-term motivator or benefit that we're getting from those new behaviors, they're likely to fade away too. So we want to be on the lookout for that as we're asking people to do new things, whether it's following a recommendation, taking a medication, engaging more physical activity, whatever the case may be. We want to not just look at what's going to motivate them in the short term, but how are we going to build in those benefits? How are they going to realize those benefits or provide some sort of reward, positive reinforcement over the long term so that that behavior continues? Now, the second problem, if it's not motivation, that's the issue. Say you get someone that's like, yes, my high blood pressure is a problem, and yes, it bothers me, and yes, I'm ready to change now. And you've asked them to, say, do more physical activity because maybe it's not quite high enough for medication. But they're still not doing it. Say you see them in follow-up and they're like, I tried to go to the gym, I got really overwhelmed. There's a lot of machines, and then I tried walking around the block. I don't know if I was doing it hard enough. We start to get the sense then that the issue isn't motivation. This person is obviously making some attempts, and they're telling us that they're really motivated to do something, but they may not know how to do the behavior. There's sometimes an assumption that people know exactly how to do the behaviors that we're asking them to do. Do they know how to take the medication correctly? Do they know how to do physical activity to the intensity to have the beneficial effect? Do they know how to cook a healthy meal? These are things that we need to be asking about when someone's not following through on a behavior. This is probably one of the easiest things to fix, to be totally honest, because we can start small and build up. We can build that mastery. Those positive benefits of doing little pieces of the behavior towards the ultimate goal will start to build, and those benefits will come along the way. That individual's confidence will improve over time. And we can do small things to help facilitate behaviors where it's just a matter of overcoming some small barrier, not necessarily increasing motivation. So it's things like putting reminders out because they just keep forgetting to take the medication. It's things like, finding an alternative food that they really enjoy that's lower in calories and fat, for example. So we can look for substitutions and alternatives It's also looking for substitutions and alternatives for behaviors that serve a particular purpose. If you've got a patient that's telling you, I just get so stressed out and I smoke to reduce my stress and I eat, unhealthy food to reduce my stress. Okay, what else can we do to reduce your stress before we try to change that behavior? We need to find some other way for you to decrease your stress or to have other coping strategies to take that place. So it's about finding substitutions and alternatives for the purpose that the behavior is serving. And you've probably heard of SMART goals. They're specific, measurable, achievable, relevant, and timely goals. I won't get into too much of the details. You can, Google this. It's pretty common, but we want to help our patients to identify SMART goals that are truly achievable and very specific to the behavior. One thing I hear a lot in my work is providers helping patients to set goals for losing weight, and they think that that's a specific goal. Well, we told him he needed to lose 10 pounds. Okay. It's specific, but it's not necessarily achievable because it's not a directly controllable behavior. I would rather see specific goals related to a behavior that the individual has direct control over. I can tell a patient, go home and do not eat the chips when you sit down on the couch, and they can control that behavior. I cannot tell a patient to go home and weigh 0.1 pounds less. It's not a controllable behavior. So when we're setting up SMART goals for people, we want to think about what is the specific behaviors that I am asking them to do that is directly controllable by them. And then you work with them to find goals that are actually achievable within their context. So that's if the problem is behavior. There's one other bucket we can put problems into. If the person's got motivation, they know how to do the behavior, they can set SMART goals and that sort of thing. Sometimes people just don't follow through on a recommendation more because there's some kind of emotional thing standing in the way. This could be, just stress. It could be something more serious like depression or anxiety. In these cases, we want to help people find ways to cope with these emotional states, or maybe get treatment for them, referring out to mental health services, helping them find medications that work for them, helping them find stress management programs, seeking out social support, things like that. But when you start hearing things about emotions getting in the way, we don't want to discount that they may not have motivation or behavior. We may just need to deal with the emotions first. This is particularly important when we get people that have huge life events. We want to give them space to deal with those life events and then come back to the behaviors. We don't want to write them off as being non-compliant or non-adherent or not having motivation. We want to be cognizant that these emotional issues can really get in the way. Okay, at this point, we're going to move more into the foundation and approach of motivational interviewing, but I do want to give an opportunity to ask questions or make comments if you have them.
And hi, Dr. Pfammatter. There aren't any questions. There is a reminder in the chat for everyone. If you'd like to access the live captioning services, you can do that by clicking on the link in the chat. So no questions at the time, so I'll turn it back to you.
Perfect. Great. So we'll move into an example we're going to go over or refer back to as we're going through our motivational interviewing principles or tenets. You'll hear them called both of those things. And in this case, we're going to take the example of a 45-year-old male. We're going to call him Joe. He has a family history of cardiovascular disease on his dad's side and diabetes on his mom's side. These are things maybe he's very concerned about. We can notice from his chart over time, he's been gaining weight over the past few years. He's categorized currently as overweight, but not obese. His HbA1c has been creeping up over time as well. We can see that in his blood work. And we happen to know through his intake interview that he's got a sedentary job. He gets less than 10 minutes of moderate to vigorous physical activity a week. I know some of the healthcare providers on this call today also work in an inpatient setting. This can go For inpatient or outpatient, we may think of it in a different context. In one case, you may be in just a typical encounter where behaviors are on the table. In another, maybe in an inpatient setting, you've got an opportunity as you're going over blood work to sort of mention some of these aspects of risk. And maybe during discharge, you're going over incidental findings. This is another place where you might be able to have some conversations. But we're going to refer back to this this case as an example as we go through these foundations. So these are the primary tenets of motivational interviewing, and I'm just going to briefly breeze through them. Again, you can access some of those other materials if you're interested in getting more in the weeds and deeper into how to execute some of these tenets. The first is asking questions, and as clinicians, we often make statements, we give advice, we direct, we prescribe, and unfortunately, this doesn't really put us in a position of collaborating directly with the patient. It often means that we miss information and miss opportunities. It puts us in a position where we're not really getting information from the patient that would help guide some of our clinical decision making. And while we might be following best practices, we might not be following what the patient is actually most likely to do once they leave our encounter. So to that end, we want to maintain open communication. What that means is that we're asking more open-ended questions. We're asking permission to discuss things. And really, if you think about it, almost any statement can turn into a question. If we're feeding back blood work, for example, in Joe's case, and we're saying, hey, your HbA1c is quite elevated. Another way we could say that is, hey, did you happen to know that your HbA1c has been increasing over time? Has anyone talked to you about that, right? It puts us in more of a position to have a conversation with Joe about what's going on with his health and invites him to be an active participant. It's actually easier than it sounds to turn statements into questions. Oftentimes when I'm training healthcare providers in using brief behavioral counseling, I will have them practice having an entire conversation full of just questions. It sounds hard and awkward at first, but what you'll get a sense of is that you can create a situation where you are collaboratively coming to an agreement on what that individual is going to do. And what you'll find is that more often they are creating a plan with you that they are more likely to enact once they leave. And honestly, that's really the goal, right? The next is express empathy. This sounds really easy, but it's actually quite easy to have an encounter where there's no empathy expressed at all because we're just giving clinical information and recommendations and prescriptions and leaving. But patients really do need to feel heard by their healthcare providers, and they're more likely to follow through on your recommendations if they actually trust you, if they feel like they've been heard. So empathy is a way to establish rapport and trust. They're more likely to listen and follow through. We can say things to express empathy pretty regularly, such as change can be really hard. Doing healthy behaviors in your social context may be very abnormal, may be very difficult. We can use skills that we'll talk about a little bit called reflective listening. We can do things like normalizing. It's quite normal for my patients to feel overwhelmed when they realize that they have some of the same risk factors that their family members who died early did as well, et cetera, et cetera. We can also summarize what we're hearing from the patient, mostly to make sure that we are on the same page, but also, again, to express that empathy. We want the patient to feel like you are empathizing with them, that you understand their struggles, and that you're there to collaboratively work towards a plan of action. We also want to take a curious and non-judgmental stance. There are a myriad of reasons why people do or do not follow recommendations. This leads naturally to asking more questions, but it helps us to maintain rapport with our patient. And it aids in truly understanding the motivation of the behavior, or if it's, again, more of a behavioral problem or an emotional problem. In Joe's case, we can get an understanding of why he's been so sedentary. If we are asking questions about, so it seems to me like you don't do too much physical activity. Can you tell me why that is? We're coming from a place where we're truly curious about the behavior of Joe. We're coming from a place where we're not judging him. We're not saying like, hey, you're not getting too much exercise there, are you? Right? We are truly curious about it. And he then feels maybe safe to open up and say, you know what, I try, but maybe I've got a lot of knee pain that I've never really talked to anybody about. Okay, now we've got a different problem to fix. Now we've got more of an understanding about why he's been doing the behavior that he's been doing. We can get to the root of the problem faster, right? It doesn't take a follow-up exam to find out why he hasn't really been doing physical activity. We can find other ways around that behavior right off the bat. Sitting with ambivalence is another tenet of motivational interviewing that's quite important, because as humans, we often have very strong feelings about two opposing stances, or in our case, we're really focused on behaviors. An example of this would be, I really want to exercise, I'm really motivated to do that, but I also deserve a break on the couch tonight. It's You'll also see it in following medical recommendations like medication adherence as well. I really want my blood pressure to get better, but the side effects of this medication are just too much for me. It's not that they are apathetic to doing the recommendation that you're asking. It is that they feel very strongly about the opposing side. We can normalize that. We can empathize with that. We can reflect on that, and we can problem solve our way through potential solutions so that we move more of the benefit towards the thing that we're looking for and away from the thing that is undesirable. We also really want to avoid argument, and this sounds so simple, but it is very easy, especially with some particular patients, to get into an argument. But unfortunately, arguments really destroy rapport. It is okay to disagree with your patient, but we can do very specific strategies to continue a conversation where movement can be made. And if you avoid the argument, you're actually avoiding the complete shutdown of the communication, where it is highly unlikely that any recommendation is going to be followed. So if Joe comes to us, it's the end of his inpatient stay, and we're going through discharge with him, and we're saying things like, hey, your HbA1c is increasing, would you like to talk about what we can do about that so that we can prevent diabetes, like your mom's side of the family? If he's saying, oh no, I am destined to get diabetes, and because of the cardiovascular disease on my dad's side, I know I'm going to have a heart attack early, just like all the men in my family did. If he's very determined in that particular stance, you could go in and say, actually, there's a lot you can do to prevent these things. There's no reason why you should think that way. That's getting into an argument pretty quickly. Instead, we can ask questions like, oh, why do you feel that way? Where did you get that information? Tell me how you understand what happened to your the men in your family. Tell me how you understand what happened to your mom's side of the family. You can ask questions or permission to discuss those issues. Take that non-judgmental stance, and you're actually going to find out a lot more about how he's thinking about those disease processes, and you'll get a better understanding of what he's actually willing to do. Or you can at least have an open conversation about educating him on what he is able to control and what he may not be able to control. Get a little bit more room for movement in that way. This goes along with rolling with resistance. When you hear patients saying things like, I just can't, yes, but, if only, it's really a no. And again, we can ask more questions to understand that resistance. We can find alternatives or reasonable options, even if they're not the ideal. We talk a lot about getting patients to do proximal behaviors, or things that are just close to the behavior. If I can get someone to wake up a little early and drive to the gym, but not actually go to the gym, I've actually created the first part of that behavioral chain in that overall recommendation that's going to just get them inching closer and closer to that ideal without trying to put all of those behaviors on the table right away, overwhelm the patient, and make it unlikely that they don't follow through at all. So often when people are resistant, we're looking for those very small behavioral approximations that give it us closer and closer to the bigger goal. And then ultimately, what are we trying to do in these encounters? When we're talking with folks like Joe, we're really trying to support their self-efficacy. Now, self-efficacy is the confidence in your ability to engage in a behavior despite there being barriers or challenges. And it is very specific to the very specific behavior and the context. I might have a lot of self-efficacy for engaging in exercise when I am at home. I may not have a lot of self-efficacy for exercise when I am traveling. Joe may feel like he has a lot of control over the food when he is out and about or at the office, but not so much when he comes home and his mom is, cooking for the entire family. He may not feel like he has confidence to really control that situation. We need to figure that out. So we want to ask questions about their context. We want patients to recognize when they have had a mastery experience, when they've actually done some piece of the behavior that we're looking for. Positive reinforcement can go a long way. We want to reward behaviors and not outcomes. So if you're talking to Joe and he says, yeah, I identified a few exercise groups in my neighborhood and I've called them to figure out what days and times they meet. I thought that doing the social thing might really help me. You're going to want to reward that behavior, even though it's not directly connected to the outcome that you're looking for, that is more physical activity, right? Because he's made the first step towards that larger goal. So you're going to give him some positive reinforcement for that. Steps towards the ideal behavior matter, and that is how we're going to support building confidence over time. So that's the basic quick overview of the foundation of motivational interviewing. Those foundations are going to seep through all of our conversations with our patients when we're using brief behavioral counseling. And next, I'll go over some very concrete skills that you can walk away with and start practicing. But at this point, does anybody have any questions about those foundational aspects?
And Dr. Pfammatter, I don't see any questions in the questions pane or the chat. And as a reminder, you can always submit your questions during the presentation, and we'll make sure to get to them during the breaks or at the end of the presentation.
Perfect. All right. So let's get into those skills. These are going to be things that you can leave here today, start practicing, and I would encourage you to do that. Find a buddy that you can practice on. Start working it into your clinical encounters. And it will take a lot of practice, but over time, these things get easier. Changing the way in which we have conversations with patients can really make a difference. And we can start small. Just like we ask some of our patients to start with small behaviors, I often have folks pick one of these skills to start with and then start building on as they feel more confident using it. And sometimes they just come along with each other. So we use the acronym OARS, OARS. I like to think of it as if I need to turn the boat around, I need to change someone's direction, I need to change their behavior, I'm going to need some oars to get us turned around, right, in our little boat. And OARS stands for open-ended questions, affirmations, reflective listening, and summarization. And they're just like what they sound. So open questions is sort of what we talked about before. We want to make sure that we're asking questions that allows the patient to give us feedback about what is going on in their context, such that we understand it quicker, such that we arrive at a recommendation that they're more likely to do. Affirmations sounds like it could be a lot of great job, or way to go, or that's so good for you, but that's not really what we're looking for when we're doing effective affirmations. We want to avoid things like cheerleading. we can support someone's self-efficacy when they have a feeling of mastering a particular behavior. And so to do that, to make sure that the patient is feeling that, we want to provide affirmations that are very specific, that point out the specific behavior they did, that empathize with them about maybe how difficult it was, that points out the barriers they had to overcome, and that reflects it back to them so that they can communicate how they feel about it, or they can at least reflect on how they feel about it. So rather than saying, you know what, Joe, I see that you're making an effort to do more physical activity, great job. We can say, Joe, I know that when you first came to us, you weren't doing any physical activity and you were finding it really difficult to know what to do and when to fit it into your schedule. But I see that you've really made some headway in creating some time and finding groups to help you identify exercise plans that are going to work for you. How are you feeling about all of those accomplishments? Right? So we're being really specific. It doesn't need to be that long, by the way. Really specific. We're pointing out the places where they've made headway, and we are reflecting back to them, how they might be feeling about that, so that we are increasing their confidence and they're not relying on us for all of the positive reinforcement. It's actually kind of coming from themselves. The third one is reflective listening. Reflective listening is much like just reflecting back or echoing back what you've just heard from the patient. And we do this for a couple of different reasons. One is it makes the patient feel heard. Joe, I hear you're saying that it's really difficult to change the way that you eat because, there's several people in your household and you're not in control of the grocery shopping and the cooking, and you feel like, you're not really confident that you can change any part of that system. Is that right? So we're reflecting back sort of what we are hearing, and in some ways we can summarize what we're hearing. We can also make linkages to patterns that we're noticing. So if we notice that Joe has a really hard time when, say, things are not planned out, if he is spontaneously having to identify healthy choices, he's more likely to fail. And maybe he's given several examples where this is the case. We can use reflective listening as a way to say, I've noticed that when you get into situations where, say, things aren't really planned out, that you're more likely to make an unhealthy choice. What are some of the things perhaps that we can do to make sure you always have a plan? So you can make those linkages by using reflective listening, so that the individual is gaining more insight about behaviors they can do that are going to generalize to a lot of their challenges. And then summarizing is something we can do typically at the end of an encounter. So as you get to the end of that discussion with your patient, you are sort of giving the highlights so that you make sure that that you're both still on the same page about what the key takeaways are and what the recommendations are going to be and how they're going to follow up, either with you or primary care, wherever you're transitioning them off to. It also allows for any correction to happen. So during the course of an encounter, Joe may find that, you made that recommendation about taking medication, but I think I want to try this other thing first. I want to try to increase my exercise and change my diet before I go the medication route. And it allows you to really solidify the plan that you've made. And then it leaves that patient with the summary of your encounter fresh in their mind as they're leaving you. So they don't have to try to really remember what happened during the entire visit or that whole 10-minute encounter. You've already given a summary to them, and they're walking out the door with that fresh in their mind. So these are the 4 things that we want to be thinking about implementing in our clinical encounters. And know that they're not things that are necessarily getting added on top of what you're already doing. It's just a way of approaching having the conversation in a slightly different way. Instead of telling the patient about incidental findings, you're more having a conversation and asking questions about the incidental findings. And instead of just prescribing or making recommendations, you're actually asking questions about whether or not those recommendations are reasonable. And over time, this can become a more efficient pipeline of getting behavior change on the table. So let's go back to today's case. Remember, we've got Joe. He's got a family history of cardiovascular disease and diabetes. He's gaining weight over the past few years. His HbA1c is increasing. He's got a sedentary job. We know that he gets very little of moderate to vigorous physical activity a week. So we're going to be thinking about using the ORS skills in our encounter with him. So think about your particular context, whether that's an outpatient clinic or an inpatient setting. Maybe you see them patients for very different reasons, but you've noticed these things in his chart and know that somebody needs to have a conversation with him. You've got an opportunity here to get these behaviors on the table. You do have a chat function here. Aside from the question and answer, you should be able to chat such that I can see it. I wonder if you might take a moment and just think of some open-ended questions you might want to ask Joe if you wanted to tackle, say, some of the preventive behaviors for diabetes that you would like for him to do. What are some open-ended questions you might start out with? Doesn't have to be very complex. Just think about what are some things I might start the conversation with? What kinds of open-ended questions might I ask? I really want him to be doing things like getting more physical activity and maybe eating healthier, reducing his caloric intake. Renee, do you see things coming up in the chat?
I don't see any yet. I believe there might be some coming through the questions.
Okay.
Oh, here's one. Tell me about your daily routine.
Yeah, that's a great one. What does that do? It gets you an idea of his total context. I will say that given your particular context, if you know that you don't have a lot of time, say you have a 5-minute encounter you got to do, that may put you down in a rabbit hole of having a too long conversation. So this is something you need to think about. What are some open-ended questions I can ask that are very specific that are going to get me the answers I need? So certainly if you've got the time, that's a great one because you can get a lot of information all at once. But I don't want people to be scared off by that either, because it will lead to perhaps a longer conversation than what you're ready for. What else can we ask Joe?
So there's a few more great ideas here. I see that your HbA1c has been increasing over the last few years. Why do you think that is happening?
That is an excellent one. You get a good understanding of how much the patient comprehends about their own health and the metrics that you're looking at. All right, let's go to affirmations. So say through that conversation, maybe he has noticed, he just went to his primary care physician not too long ago and knew that that was happening. And he has started to decrease his caloric intake. Maybe he started tracking on MyFitnessPal and he's telling you about this. What are some affirmations we can do or say to Joe? Remember, we want to give some positive reinforcement in a way that is really specific so that we're reinforcing the behavior towards our ultimate goal of getting those metrics to be in a more desirable direction. Any ideas there?
So here, there's a few coming in. These are great. This is great that you have started using MyFitnessPal. Here's another one I really like, that you downloaded an app to help you track your exercise, caloric intake. How are you finding that you are feeling since you started decreasing your caloric intake? And several
That's
others.
a great one. You've got a nice open-ended question rolled into a bit of an affirmation. Yeah, so even with that example, you can start to see where you can overlay some of these skills to really make your encounter more efficient, right? You're providing some affirmation while also keeping the conversation going in a direction where you're gathering information about these behaviors.
Here's another one. Your activity seems to be paying off. How does it feel to see those results?
Yeah, if you see any indication, especially in the metrics that you're seeing, certainly feeding those back to the patient and connecting them directly to their behaviors is really great. I think the issue sometimes that we see with behaviors is that the patient themselves, they don't always see the benefit. This happens with medication too, right? If you've got someone with, high blood pressure and they start taking medication, they might not always feel any different, right? So it's really important that we connect the behavior. That is, I see that you've been taking your medication and it's paid off because now your blood pressure is under control. And then we also perhaps even want to go a step further to say, uh, you know, that is really going to play a big part in preventing, cardiovascular disease down the road, which is, I know, something you were concerned about with, right? And, you're opening up that conversation to them to, provide an affirmation, summarize what you're seeing, and then giving it back to them to see how they're feeling and thinking about it, right? And you've created this conversation where you're supporting a behavior, you're providing positive reinforcement in a way that is really informative to the patient and opens it up to get them to really express to you how they're feeling about it, so you know if they're going to be likely to continue to do that behavior. So yeah, we can overlay those. Let's go through the last two are somewhat related. So reflective listening, we use more in the moment to make sure that we're on the same page. Perhaps Joe is telling you, I want to change my diet, but I don't have much control over what is coming into the household. My wife and mother take care of that for me. And so I just eat what they put on the table, and they're in charge of that. I don't feel like I can change that at all. What kinds of things might you say to Joe if you're truly reflective listening back to him in a way that's going to move this conversation forward?
And Dr. Pfammatter, while we're waiting for those to come
Yeah.
in, I did want to let you know we're at 2
Yep.
minutes to the hour. I think this one's, everyone's probably thinking about it.
Mm-hmm.
Let's see. So I hear that you don't have control over the food preparations at home.
Yep.
That's one.
So yeah, I might say things like, I'm hearing that you don't feel like you have control over certain parts of your diet. Maybe could we talk about places where you do, right? So you're always looking for those other opportunities. And then, as I said before, summarizing is going to happen more at the end of that encounter as you're going through the highlights and really coming to an agreement on what the next steps are. Good. Thanks for participating in that. I think that's really helpful for people to truly think about what do these skills really mean in terms of the words coming out of my mouth, right? So again, OR stands for open questions, affirmations, reflective listening, and summarizing. So just as a summary here, I really encourage you to commit to focusing on one skill and practice, 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 adding them on, making them more complex, or using them more in a compound way as you move along. Try them on for size in your encounters, particularly when behavioral challenges are on the table. We know that these brief behavioral counseling skills can really help in moving people towards healthier behaviors. And think about what motivational interviewing approaches might work well in your particular context. I did put some additional references at the end here. And if anyone has any burning questions, happy to answer those here in the final minute.
There was a question earlier asking about in general, is there a time frame that you set with your patients to change a behavior?
Oh, yes. So if you're setting SMART goals in particular, you want to make sure that they're always bound by time. So if you're putting, say, physical activity on the table, you want to really have that conversation with them about what they think is reasonable. So do you think you can do, 20 minutes of physical activity 4 to 5 days per week? So those usually come out in the SMART goal setting. Now, if you're talking about time frame in terms of the trade-off between lifestyle factors before you do more intensive medical interventions, that depends on your own clinical judgment to some extent. Um, but putting some bounds around it so that people know that it's serious enough to warrant some kind of medical intervention, but you're willing to give them a little bit of latitude, say for 2 to 3 months, to try to get the numbers in check. Sometimes that can be a powerful motivator, and people do need those sort of deadlines to get things moving. And then depending on how much they moved in that time frame, I might allow some additional time. It really depends on how you're feeling and how bad the numbers are, really. Any other
Thank you, Dr.
questions?
Pfammatter.
Great.
I believe we don't have any other
Yeah.
questions, but I'd like to thank you, Dr. Pfammatter, for leading today's webinar, and thank you for your participation in today's event. Just a reminder, after today's webinar, you will receive a follow-up email with a survey on the presentation. In that email, you will also receive a link to view a recording of today's presentation. On behalf of the American Heart Association and our presenter, thank you for joining us and have a great day. This concludes today's presentation.
Thank you all.